Okay, very well. Well, welcome to our webinar this evening. I'm so thankful that you're here. I want to check and see if you can hear me and see me. So I see your face, and yes, you can. Okay, very good. Well, let's get started. I'm excited to be here tonight. We're going to go over what I think is a very important fundamental step to really have success in some of the more difficult cases. And I say this because a lot of times, here's what I find. I find that when I have the more complicated cases, the very first thing I do is go to the fundamentals and go to the very basics. Because many times people will come in and maybe they've been everywhere. They've had parasites checked for heavy metals. They've done this, they've done that, MTHFR, they've done all those things. And if you'll do basic work, a lot of times you'll see something simple, like they've got a chronic infection they didn't know of, or maybe they have some blood sugar dysregulation that needs to be taken care of, or maybe they have some kind of liver congestion. They've got something going on that's very basic and simple. So when we go through the history, we're really going to talk about in this session right here how to identify those very fundamental things that can be going on that can be giving you a lot of problems in your clinical success. So let's start here. I always like this right here. This is a quote. Let me write this down. Thousands of loyal patients who depend upon their chiropractors for health maintenance and treatment look to their DCs as total health practitioners and as often as family advisors. It is incumbent upon us, therefore, to provide the kind of well-informed, conscientious health and family advice that we are in a position to offer. There's really no question. Lots of people coming to us because they trust us. We're the natural doctors. And if the better the examination we're able to do, the better our procedures are, the more they're going to trust us with even more serious cases and family and whatnot. Chiropractic and wellness right here. I like to point this out. There's 4 leading causes of death: heart disease, cancer, stroke, and COPD. All of these are largely preventable or even reversible when you can identify the major drivers. One of the things we talk about in the DAPSI program, the chiropractic internist program, is how to understand and recognize conditions or things that drive these problems and how to monitor it so that you can make sure that you're making the proper success. Okay, so I want to show you this first. This is a great place to start. If you've been around my teaching before, no doubt you've actually seen this. This is a pyramid. This is actually published by Dr. Ali. He's talking about liver detox, and it was in Townsend Letter 2007, a lot of years ago. But the concept was really good, and I want to explain. I kind of took that concept and I've built on it. I don't want to take anything away from Dr. Ali's work, but I just want to show you some of the things that we look at right here. So there is a pyramid here. And at the base of the pyramid, we have things like the liver function. We have things like what's floating around in the blood. And then we have what's called the gut-brain axis. Now, the brain-gut axis, blood and liver, this is pretty much what drives physiology in the body. All physiology begins here. Brain-gut, gut-brain axis, what's floating around the blood, and what's going on in the liver. So when we do a history, we're going to do a history in such a way where we can check these boxes till we see how the liver's working, what's floating in the blood, and how's that brain-gut, gut-brain axis doing. Now, as the pyramid showed, if people start having difficulties and maybe some liver congestion, maybe some anemia, low blood sugar, high blood sugar, insulin, infection, things that float in the blood, or maybe they have a gut-brain issue, any one of those things can start driving the second layer, which are things like thyroid problems, things like adrenal problems, and insulin problems. So this is kind of the second layer of what happens when there's something down here going wrong. Now, when this is going wrong, here's what's going to happen. Somebody comes in, they have thyroid issues. Very common complaints for thyroid is going to be fatigue. Patients are fatigued. They have a hard time losing weight, even though they're on a low-calorie diet. They exercise like crazy, eat like a bird. they can't lose weight, and dry skin, that's actually a very common one. Brain fog is very common, and constipation. If you were to ask me, what are the 5 most common symptoms for a low functioning thyroid, I would say this would pretty much get it. Fatigue, weight gain, brain fog, and if you ask them, do you have dry skin? Oh yeah, my skin's dry. Are you constipated? Yeah, I'm constipated. These are 5 common symptoms of thyroid. So somebody comes in and they say, I have fatigue, weight gain, even though I eat like a bird, I'm in the aerobic, I do aerobics 90 minutes a day or whatever the case may be, my skin's dry, brain fog, and I'm constipated. They tell you all these things. And so that tells me that probably there's an issue going on with thyroid function, but it still doesn't tell me why. So I back up this way to see if there's anything going on with the way the liver's working. Is there anything floating around the blood? Or is there infection going on? Blood sugar dysregulation? Is there anemia going on? What's going on in the brain-gut axis? What's happening in these measures? And so I'm going to look at this and see if anything down here could actually be driving that thyroid problem. Because there is a case, you could have Hashimoto's, and you could even have just a primary thyroid problem. Now, once you either have a thyroid, adrenal, or an insulin problem, then it generally leads to the next cycle, which are sex hormones, hormonal imbalance, limbic system issues, and neurotransmitter issues. So people come in, oh, I'm low in serotonin, oh I'm low on dopamine, or you know, they have anger and they're rage, they're real ragey and things like this, limbic system, or you know, they have hot flashes, they have other signs of hormonal imbalance. Well, when you see that, you don't just go in and try to pick up the latest neat little nutritional gadget that you can use for one of those, but you look under the hood. Is there something going on with the thyroid, adrenal, insulin? Is there something going on in the base? Now, keep in mind, once somebody has, for instance, let's back up a little bit here, and let's say that somebody has issues that they have a congested liver. That congested liver, let's say in my example, is causing poor conversion of the thyroid hormone, so they have low thyroid function. So this person has low thyroid function, so they're going to be fatigued, weight gain, brain fog, dry skin, constipated. So these things are happening. Now, lo and behold, because the thyroid isn't functioning well, now the liver's becoming even more congested, so these things just cycle on themselves. So I want to show you that if you've not seen it before. I know I've gone through this before in other classes, and that's really where we came up with this idea of Bile amount. Now, Bile amount, I have a whole bunch more things in here, but these are really what I would call the 6 fundamentals. So when somebody comes in as a patient, no matter what you do with the patient, you always want to check these 6 things, no matter what, because these are what are called deal breakers. These are things that if you don't address them, then the patient's outcome is going to be limited to the level that you have not addressed this. Let's put it a different way. Somebody could be having, you know, chronic fatigue, and you know, you've given them different things for chronic fatigue, but you never address the anemia. If you don't address the anemia, you know, chronic fatigue is always going to be there to some level. You're not going to have complete success. So no matter what a patient comes in with, whether they're diabetic, they have Hashimoto's, whether they have cancer, what are the reason that the patient would come visit me? When I first start with my history and I first start with my care, I'm going to look at these 6 basic fundamentals. If there's a problem with any one or more of these, then that's the first order of business. Before I really start anything else, in most cases, I'm going to go after these 6 fundamentals. That's blood sugar regulation, and believe it or not, you're going to find somewhere around 90% of the patients that walk into your door are going to have either hypoglycemia, reactive hypoglycemia, pre-diabetic, insulin resistance, diabetic. They're going to be somewhere in that spectrum of blood sugar dysregulation. You'd be amazed at how many patients I've had referred to me from doctors, and you know, multiple, multitude of problems and have a hard time getting anywhere, and we find out their primary problem is they've got reactive hypoglycemia. Balance and structure, that's our chiropractic work. Anemia, oxygen, what's going on with there? Do they have anemia from iron deficiency? Do they have low thyroid? Do they have B12 deficiency? Do they have folate deficiency causing anemia? Do they have oxygen deprivation because they have low blood pressure? If the blood pressure is lower than 110/70, either one, that's too low. So somebody comes in, they have blood pressure of 100/60, then what happens is they don't have enough pressure to push the blood into the base of the brain, and they're not getting good oxygenation of the brain tissue, the brain cells. So this can be a cause of a problem. So that would be something that would need to be dealt with. Infection, inflammation, liver, GI tract, what's going on here? So just to sum up before I move on, when a patient comes in, no matter what they come in with, maybe they just don't feel good, or maybe they do come in with Hashimoto's, or come in with, irritable bowel syndrome, or they come in with whatever you name it, these are the 6 fundamental things that I want to take care of. All right, so history really is the key to primary care, and that's what we're doing. We're doing primary care. I would actually argue the fact that we can produce family care better than the family medicine doctor that's the average family medicine doctor that basically takes people with blood pressure, high blood pressure, and gives them a pill, takes people with cholesterol at 240 and gives them a pill, takes people with this, that, and the other and basically prescribes pills. We can actually fulfill the definition of family practice, which is about seeing all cases, all ages, becoming the hub of support for care, and also being able to teach them with prevention and health measures and so on and so forth. So here's the flow chart. This is a metabolic clinical decision-making tree. So a patient presents into the office. We're going to have them fill out some intake forms, questionnaires. When you do the history, I highly suggest that you use questionnaires, because if you try to do it by, I've heard some people say, I do a history and I just start off with a blank piece of paper and we just sit there and talk. Well, I mean, there can be some value to that, but I would say at the minimal, you want to start with a questionnaire. I have multiple questionnaires I have them fill out. Before I even see the patient, I can already tell you, out of the 6 things I have listed, I can already tell you 1 or 2 or 3 of them that's probably going on with this patient. I can say, you know what, I bet this patient's got a lot of inflammation. I bet this patient has some liver congestion. I bet they've got some blood sugar dysregulation. Before I've even seen the patient, I can start formulating some ideas of direction and where we want to go. Now, that's important because we're going to get to the place where we take the intake forms and take what we observe for them, and we're going to put it together with some kind of idea of what could be happening. And that way, when we get to the physical exam, we can be even more efficient with our physical exam because we're not missing things, because we already have some kind of idea of what we're looking for. And I don't get too far ahead of myself, but when you do a physical exam, there should be a core physical exam that you do on pretty much everybody. And then depending on the case, you may add 1 or 2 elements as you need there. But this is basically a flow chart, because at the end of the day, we want to develop a long-term strategy for maintenance of the continued health. So this is brought upon by this history. By the way, one other thing to say about history is this is a good time to start really building a relationship and trust with the patient. As people share with you problems and so on of whatever is going on with them, it helps them build a bond with you. And we don't do the history just for that, of course, but that's one more added benefit of sitting down and listening to getting a history down. Now, before we close here, what I'm going to do is I'm going to go through a case study, which I think will be good for you. And I'm also going to go through kind of a rough outline how I do my history. So stay tuned. We're going to be done, I think, maybe at 8 o'clock, maybe a little bit beforehand. I'm Central Standard Time. Okay, all right. So history and exam begin before the patient is seen. So here's some things we want to look at. The reason why the patient comes in. Why are they coming in? Maybe they're coming in and they say, I just saw my schedule a while ago, looking for my new patients for tomorrow. I had one patient coming in because they're having bloody stools. Another patient's coming in. I forget what the complaint was, but it seems like I'm thinking Hashimoto's, but maybe I'm wrong. But anyway, those are two cases that I'm going to have tomorrow coming in. Now, I already know before I get started with this patient, they have bloody stools. I can already in my mind start thinking about, is it an infection? Is it an irritable bowel disease like ulcerative colitis, Crohn's? Is it coming from food sensitivities? I wonder how long those patients had that, and then I can start developing some ideas. I wonder if they traveled, out of country. So I already have these questions in my mind. I haven't even seen the patients. They're going to be here tomorrow. I'm just showing you real time how I would handle that. Punctuality. This is actually important. Here's one thing that happens. When we look at the brain, the nose, and the mouth, different neurotransmitters do different things. There's something called acetylcholine, and acetylcholine is actually what provides speed to the brain. Acetylcholine is the neurotransmitter, the neurochemical that provides speed to the brain. So one of the things that happens if somebody shows up late, or particularly say somebody's appointment's at 10 o'clock and they show up at 8:30, this is sometimes like an older person and they know that they're slow, so they want to come a lot earlier to make sure they can get all their work done. This is probably somebody with maybe low speed in the brain. So you can start kind of thinking about those. How long does it take to fill out the forms? And how well did they fill out the forms? You have all these questionnaires and, do you have foul smelling breath? Do you have belching, burping? Do you have XYZ? And they're just 0, 0, 0, 0. The whole form says 0 on it, meaning they're not admitting to anything. Well, you know that this case is going to be a little bit more difficult to pry loose. They're probably a one thing's going on with them. They want you to look at that one thing and fix it, and then they're done. Maybe it's musculoskeletal. They came in, they have shoulder pain. I don't want to talk about my thyroid. I don't want to talk about my hormones. It's just my shoulder pain. So you're gonna handle that patient differently than the one that comes in and you ask them, do you have foul breath? Do you burp and belch? Do you get bloated after you eat? And there are 3, and there are 2, and there are 3. This person wants to talk about that a little bit more, and it gives you an entrance to be able to start the process of really becoming the primary care for this patient. Now, you can still be the primary care for the other person. It just takes a little bit more work. If I have time at the end of this, we'll talk about some of the strategies for doing that. Okay, so handwriting. I'm going to show you some examples. Sensitivity to stimulus. They come in and they have glasses on their head, or light bothers them because they have a migraine, things like this. Overall mood, what's their mood like? Are they a sourpuss? Or is it because they just don't feel good? Or is it because they're just a negative person? Is it, are they in a foul mood because they just hurt? A lot of times that's the case, right? One of the things we try to do, somebody comes in, when they first come in, if they're all sour, we kind of make it a game to see who can cheer them up, So look at their gait, look at their appearance, how are they dressed? You have somebody coming in that, they're dressed to the nines, they look good. You see, the hair's in place. By the way, my hair looks crazy tonight. I just got off the racquetball court and threw on something, came over here. That's the reason why I kind of look a little crazy tonight. Sorry about that. But anyway, how kept are they, or how unkept are they? That gives you an idea where you can start formulating some ideas of what's going on with the patient and what you're going to do to deal with it. Let me show you something here. Here's macrographia. This is somebody who, just has big letters, and the reason why they do that is because when you look at the brain here, this is the left side of the brain, right side of the brain stem. Well, here's the cerebellum. The cerebellum is controlling fine motor movements. And if somebody has a problem with the cerebellum, one of the adaptations would be just to write bigger, because then you don't get down to small, minute movements, which are more difficult to coordinate. And so they might not even know they're doing that. But when you see big, sweeping, this kind of lettering right there, you want to think about the cerebellum. Keep in mind, just so we're here, that a lot of times if somebody has Hashimoto's, the antibodies that attack the thyroid, the TPOs, are the same antibodies that can actually attack the cerebellum. In fact, somebody might not even have Hashimoto's, they just might be gluten sensitive, and it can attack the cerebellum. So there's just some clues. So somebody comes in, and here's how we do it. Somebody comes in, they have big sweeping handwriting. Before I've even seen them, I know that I'm going to make sure I do all my cerebellum tests. I'm going to make sure I do my heel to toe walk, my finger to nose. I'm going to do dysdiadochokinesia. I'm going to do the heel down the shin. I want to evaluate the cerebellum pretty closely because it can give me a clue. Now, somebody comes in, they have a bad cerebellum. They're 45 years old. They shouldn't have a bad cerebellum like that. They're not 85, right? Well, that gives me a clue. Why is it bad so fast? Have you always been like this? No, I've always had good balance. Just recently, I've lost my balance. Better look for an autoimmune. Or, no, I've always been bad. I was car sick as a kid, this and that. You might just have somebody who had a poorly developed cerebellum. So just some ideas. I'm not really trying to teach the brain work so much, just giving you an idea how you would unpack that when you see that from a history standpoint. And that's essential tremors there. This, of course, you know, is a big clue right here to the essential tremors. You know that. You can just see these people. Also, there's micrographically, of course, especially if it's progressive. You see that Y right there and how that one's smaller. If somebody is beginning to develop problems like Parkinson's or movement disorders, what will happen is as they're writing will get smaller and smaller into micrographia. One of the things that's going on here is just to look at it. Here is the brain, the nose, and the mouth. Here is the brain stem. Down here is the basal ganglia. Right here is the thalamus. All movement happens out of the frontal lobe. And basically, when you want to move, the frontal lobe sends a message down to the basal ganglia. Then the basal ganglia turns on that movement through the thalamus. Well, what happens in Parkinson's is right at the lower base of the basal ganglia, the substantia nigra is supposed to release dopamine. And when somebody's developing Parkinson's, it doesn't release dopamine, and it's dopamine that fires up the pathway that gives you movement. So what'll happen is somebody is writing like this, and then their writing gets smaller and smaller because they're getting less and less dopamine to the basal ganglia, and basically you're just shutting down. So here's, you see somebody that writes like this, you want to think about basal ganglia problems. Right here's another good example. See where the P's start big here and they go smaller and smaller through the time. That's a micrographia. Just as a short tip, if somebody that comes in, they have micrographia. Somebody has micrographia. The next thing you want to ask them is, do you have constipation? And that's not relieved by doing natural things. Like you take senna, you take magnesium, you take, psyllium seed, you do different things, Miralax, but nothing really works. This would be a sign of possible Parkinson's because Parkinson's actually begins in the GI tract. It begins in the GI tract and goes up the vagus nerve up to that substantia nigra. So you start developing those alpha-synuclein proteins. You begin developing them in the GI tract, and then they go up to the substantia nigra, and it causes you not to be able to produce the dopamine. So constipation, frozen shoulder. So if somebody comes in, they have a frozen shoulder, if they've had one in the past without reason, they didn't fall, they didn't do anything, it's just frozen shoulder for no reason, constipation, and they micrographia, you really want to evaluate them for the possibility of early onset Parkinson's. Just more examples here. Okay, appearance. Somebody walks into your office, they have sunglasses on their head. Well, here's the thing, that one of the things that happens is we have cranial nerve 3. Cranial nerve 3's job, one of its jobs, is to constrict the pupil, and it'll especially do this when there's light shining, when there's lights in the pupil. Okay, if somebody has a lot of stress in the brain, maybe it's because they have low blood sugar. Let's just give it that. You have low glucose, and so what happens, here's a kidney. Above the kidneys, you have the adrenal glands. So when you have low blood sugar, your hypothalamus communicates with the pituitary. Pituitary sends that alarm called ACTH to the adrenals to kick out cortisol. and then cortisol quickly gets sugar and oxygen to the brain. You do this day in and day out. What happens is, here's your sympathetic nervous system pole here, here's your parasympathetic nervous system here. We should live somewhere in the middle. And so when it's time to move our bodies, we go this way. When it's time to rest and digest, we go this way. But we always kind of find true north here. But when you have, for instance, low blood sugar, and you're having to hit this alarm system all the time, and then you hit the epinephrine switch on and on, what happens is you move your towards sympathetic dominance. When you get to sympathetic dominance, you actually weaken the parasympathetic response. Cranial nerve 3 is a parasympathetic nerve. And so therefore, when light shines in the eye, you're unable to constrict the eye good enough, well enough, and so you get too much light and you become light sensitive, and you're wearing sunglasses. So somebody wears sunglasses on top of their head, or wears sunglasses when they're inside, this could be a clue. It could also be a clue, maybe they have migraine headaches, but you want to look at it. This is the way you look at an appearance and come up with an idea. When somebody has Parkinson's, one of the things that people will say, early Parkinson's, people, well, if somebody asks somebody, hey, are you upset? Are you mad? Are you agitated? Because what will happen is you start developing a mask-like face, and when you're developing a mask-like face, you lose the ability to have kind of that smile or that vibrant look, so your face kind of swoops down. When it does, that's called a mask-like appearance, and it makes you, you look like you're mad. This guy's maybe happy, but when you're looking at him, he looks upset. Why? Because that's the early Parkinson's look. Acanthos nigricans, if you see that in the back of the neck or underarm, you think insulin resistance. Skin tags, you don't think about insulin resistance. So here again, we haven't even really delved in to do a physical exam yet, but you're just looking at a person that has skin tags on the base of the neck. You already know, looking at that, there's a good chance insulin resistance could actually be what's causing that problem. Central obesity, you see this right here? You're seeing somebody who has insulin resistance. We used to call that a beer belly, then we called it a wheat belly, and now we just called it an estrogen factory, because that's what this guy's doing. His testosterone's getting shunted over, and he's making a lot of estrogen out of it. He's insulin resistant. This is a big deal. You see this. By the way, we're teaching a course next weekend. I think it's December 5th and 6th. It'll be the DAPSI program. I want to invite you right now to be there. We're going to go in depth on history and physical exam and go a lot further into some of these things that we're talking about here. But I'm going to show you a lot more of these during that course. Annette, Dr. Annette, are you there? And can you give them any information on how to do that? We're kind of at the halfway point here. And if not, I'll get you some information. If you look at this right here, you see where you see that extra pigmentation there? You'll see that when somebody's developing melasma, that's a sign that their estrogen is too high relative to their progesterone. It's an estrogen dominance. You see a decrease, you see a diagonal crease in somebody's ear, that is a sign of decreased circulation, because the support structures that hold the ear right there intact, not the ear, but that fold, in fact, intact. When you have drops in circulation, that breaks down, and then you get the diagonal crease. All right, so let's talk a little more specifically about family history. Tendency for many disorders are inherited. You want to take a look at your family history and see if anything's going on with the patient. Okay, successful lab orders begin with a good history and physical exam, but it starts with a history. How's the bowel function, blood sugar regulation, adrenal function, thyroid, hormonal assessment. We can see all this from a history questionnaire, and we're going to talk about that. There's something that Dr. Tatis Karazian developed many years ago called the Metabolic Assessment Form. I use this. I think a lot of people in the functional health world do. And what I like so much about this form is it goes through each one of these categories. Right here is talking about colon health. And by the way, I'm going to go through each one of these. This one talks about hypochlorhydria, hyperchlorhydria, pancreatic function, liver function, low blood sugar, high blood sugar, low adrenals, high adrenals, thyroid low, thyroid high. Just to give you an idea, and here's pituitary hormones, sex hormones. So it goes through a lot of these very basic fundamental things that we've talked about when you do the Bile amount. Because remember, when we talked about, let me get this over here, when we talked about Bile amount, when somebody first comes into, sorry about that, when somebody first comes into your office, regardless of the symptoms, I always want to encourage you, you want to check their blood sugar. You want to check what's going on with anemia, oxygen. You want to check to see what's going on with inflammation. You want to check to see if they have any infections, and you want to check to see if they have any liver, GI issues. So these are all fundamental things. And so when I say that, we get to this point right here, this form is covering this very well. So I'm going to look at this form before I even see the patient. And that way I know, wow, this person probably has a low blood sugar problem. We're going to go through that. We're liable to see maybe some fasciculation of the tongue. We're liable to see some sympathetic dominance if somebody has had reactive hypoglycemia for a while, or maybe they do all the thyroid ones. This is, you know, it's really heavy in the thyroid area. Then we know, hey, we need to really focus in on that thyroid. We want to make sure, you know, we're looking at the lateral third of the eyebrows when we do our physical exam. We're going to teach that this next weekend. Scalloping of the tongue. We're going to look at the coarse hair. We're going to do the Achilles reflex. We're going to look for dry skin on the heels. We're going to go through that thing. So that's just some ideas of how you would use this to really have high impact. Before we go in this, Dr. Karazian came up with just a fantastic idea here, and that's this. He said, list the 5 major health concerns you have in order of importance. So somebody comes in, they have written down here, diabetes, cancer, hypertension, and shoulder pain, right? Okay, so they come in on their form and they put shoulder pain on their form as the reason why they're there, but they're telling you right here they're concerned about those things. So that gives you an inroad to be able to begin to talk to them about these fundamental drivers, about a health and wellness you know, paradigm that you can offer them. All right, so this is the first one. This has to do with colon health, and how you would use this is first, you're going to have them, if they never have it, it's 0. If 25% of the time it's 1, 50% of the time it's 2, nearly all the time it's 3. So they're going to go through and they're going to give you 3, 3, 3, 1. So if you see somebody like that, without even reading these questions, which you should read the questions, but you're already going to know this person has problems with the colon. So we're going to deal with that. The next one is on hypochlorhydria. This is a big deal. When people have low hydrochloric acid, by the way, nothing happens good lower than the stomach when you have low hydrochloric acid. You know, they're going to have excessive belching. They're going to have possibly burping and bloating. They're going to have offensive breath and gas immediately following a meal. So these are all signs of low HCl. These right here are too much or elevated HCl, the one in category 3. This one right here talks about the pancreas and the small intestine. What's going on here? Somebody has excessive passage of gas, stool, undigested, foul smelling. We can think about the small intestine's pancreas problems. You know, mucus lice, greasy or poorly formed. You know, these are all can be signs of pancreatic and or small intestinal problems. So when somebody comes in and they're all over the place here like this, we know that, hey, we better focus in on that. That's even before I get started with the patient. This one on it here is liver, gallbladder, liver, gallbladder. So, you know, if somebody has a history of gallbladder attacks or stones, automatically you want to think about one of 3 things. If somebody has history of gallbladder attacks or they've had their gallbladder removed, either one of these, you want to think maybe this person has low functioning thyroid. It's a common cause of that. Maybe they have too much estrogen in their system, or maybe they're insulin resistant. So low functioning thyroid, elevated estrogen or insulin resistance, or a combination of these can all make the bile flow sluggish. So immediately when somebody does a 1 or a 2 or a 3 in these, it always takes me, or yes on that one, it always makes me immediately think, oh, I wonder if they have a thyroid, estrogen, or insulin resistance problem. Guess what? When I question them, I'm going to ask them questions. I'm going to look at the form. about insulin resistance. Do they have it? I'm going to look at them. Do they have a big, central obesity? I'm going to look at, thyroid, look at the form. Estrogen, I'm going to look at the form. It's all within this form that you can see it. Here's the blood sugar one right here. These are all ones that have to do with reactive hypoglycemia. I will tell you, probably the most common ones I see is irritable meals are missed. That's an important one. And eating release fatigue. All of these are important, but if they give you a 1 or 2 on these two, it doesn't matter clinically, or it doesn't matter what labs show you. I can tell you this person most likely has a level of reactive hypoglycemia. So I'm going to take care of this person as exactly if they have that. Regardless what's going on, what I find through the blood, if they get irritable if meals are missed and eating release fatigue, and they have a few more of these others, I'm going to take care of them as a hypoglycemic when I first get started, because they're having some blood sugar crashes. Even if they have an elevated fasting blood sugar, they might have an elevated blood sugar, insulin resistance, but they still might be crashing. Don't have time to go through this so much tonight, but let me just say this. If you have somebody with insulin resistance and they're reactive hypoglycemic at the same time, treat them as a hypoglycemic, because if you treat them as a hypoglycemic, the insulin resistance can get better. If you treat them only as insulin resistant, you can actually flare up the problems with the reactive hypoglycemia. You want more meals and snack time with people with hypoglycemia, because you want to help regulate the blood sugar, clean out that liver, get to the reason why they have the reactive hypoglycemia so they can normalize. With people that have insulin resistance but no hypoglycemia, then you want to take care of them by less meals, maybe 2, maybe 3, maybe 2 bigger meals a day, no snacking in between. So you're going to take care of those 2 differently. So it's important to know. So if you have these show up over here, you always want to take care of them regardless as the hypoglycemic until these symptoms here begin to settle down, and then maybe you can switch over to the insulin resistant diet where they're eating no snacks and 2 meals, maybe 3 big ones a day. Okay, so this is our adrenal one. Can't stay asleep, crave salt, slow starter in the morning, dizzy when standing up too quickly. These are all signs of that. Of course, when we look at things that are going on, right here, let's do this one. Here's the, here's the nose and the mouth and a kidney. Here's my adrenal glands right here. Adrenal glands are the sympathetic nervous system in the body. They're what release cortisol and epinephrine, norepinephrine. These are all sympathetic chemicals, neurochemicals, hormones that come out of the adrenals, right? So the adrenals are primarily your sympathetic system in the body. But what happens is when we chronically go to the adrenals and kick out this cortisol loop or the epinephrine loop, when we chronically do that, what happens is not only do we shift more to a sympathetic dominant mode, but we can fatigue these adrenals out, and now you can't make the cortisol as well. And that way it screws up your sleep-wake cycle, and so you can't stay asleep. You're trying to sleep, but your cortisol keeps bouncing around and waking you up, or your epinephrine's bouncing around and waking you up. You're a slow starter in the morning because your cortisol, it goes like this. So here's the AM. Here's the PM right here, right? Cortisol is at its highest level in the morning, and it goes down like this. Well, when somebody starts having problems because they've had so many so many problems. Here's the adrenals right here with this adrenal loops. These adrenal loops are all screwed up. You can't release the cortisol well. Now you have somebody that has a loop that maybe goes like this. So when it's time to wake up in the morning, the cortisol's not there. That way they're not getting sugar and oxygen to the brain. The brain's not turning on. We've got a slow start in the morning. Then when it's time to go to sleep at night, that's when the cortisol begins to rise, and you can't fall asleep when your cortisol's rising. So a lot more to that. I just wanted to hit the idea in this conversation, the importance of being able to understand this, because if somebody is all over the place on this one right here, if somebody comes in and they're scratching a bunch of these right here, I'm going to say they probably have some adrenal issues. And my question is, if you remember, my question would go here then. Here's what I would do with that. So somebody comes in and they have obvious adrenal issues, right? So what am I going to do? I'm going to go down here. I'm going to see what's going on with that liver, what's going on in the blood, what's going on with the brain axis, because this could be what's driving that adrenal issue, and probably is. Now, will I need to support the adrenals? I'll figure that out when I do my physical exam. I do my blood, I do my stuff. But for now, when I see the adrenals, I'm going to back up and look this way. Okay, I hope that makes sense. All right, so here is also more, this is hyper. You know, there's two sections here. Let me back up just a little bit because we should do this. This is what's called the hypoadrenals, this section right here, and this is hyperadrenals. But what you'll see is that there's so much overlap. Some people are hyper and hypo at the same time. So don't put all your eggs and try to decipher between, oh, it's hyper and hypo, because you can't really do it that way. It's not efficient. This section right here talks about low functioning thyroid. So somebody comes in and they circle a bunch of these. We already know before we get started, I'm going to ask them questions about the thyroid. And when I do my exam, I'm going to, as I said before, I'm going to be looking for the tongue, looking for scalloping. I'm going to look at the heels, see if they're cracked. I'm going to do a Achilles heel reflex. I'm going to look at their hair, see if it's coarse. I'm going to make sure if it's not filled out somewhere. Do you have constipation? Do you have brain fog? So that's how I'd use this. Okay, so these are more, this is hyperthyroid, so too high a thyroid. That's what this one would depict. These have to do with pituitary, and this is male hormones, testosterone, and this is female hormones and estrogen. So that's how you put all that together. And before you even get started, you can go through the process of understanding what could be driving the person's problem. And that really is the key. So many times we don't have clinical success with people because we jump too many steps ahead before we've really gone through these basic fundamentals. This is also a good one. It's one of my favorite ones. List the 3 best foods, healthiest foods you ate in a given week, and give me the 3 worst. If they write on here like epic bacon bar, right? That's the worst food they eat. I can tell you this person's going to be a lot harder to help and to manage, not manage, but they're going to be a lot harder because they've already done all the easy stuff. You're going to have to really work harder on this patient because they've got some underlying things going on. Yes, fix the fundamentals, but you're probably going to have to go farther. Now, somebody comes in, they write on here the 3 worst food: chips, ice cream, and Dr. Pepper. And they come in and they're tired. They have some thyroid issues. They don't sleep good. They have weight gain that they can't explain. And they have these things right here. Guess what? You know, 95% of the time, you're going to look good in this patient's eyes, and it's going to be easy. You're going to do your exam. You're going to get your blood work. You can show them how they're killing themselves, one fork bite at a time, and then they're going to get motivated. They're going to get off the chips. They're going to get off the ice cream. You're going to do food sensitivities. They'll get off gluten. They'll get off dairy, and then they'll eat good foods. You'll do a nice blood sugar boot camp on them, and they'll think, Doc, I lost 30 pounds in 3 months. You are a hero. Well, they were just eating junk food. But you take the same person with the same symptoms, and the worst food they eat is an epic bacon bar. Sorry, Charlie, this one's going to be a little harder, but still start with the fundamentals. You want to start with the bail them out, because if you miss those steps and you have a more complicated case, good luck. You're really not going to have as much success with that. Okay, so I want to take a minute and go through a case study to show you kind of how I would use this. All right, so this is the patient that came in, 19-year-old female, presents with passing out without known cause. All right, so 1 week prior to her visit, patient had consulted with neurologist at Barnes Jewish Hospital, St. Louis, without resolution. Okay, so what do I know before I even get started here? Well, I want to show you something that is really important. This is just something that if you've been around my teaching, you've probably heard me say this before, but when the autonomic nervous system is laid down, it's laid down in 3 layers. We have 3 layers to our autonomic nervous system. The very first layer is what's called the unmyelinated vagus nerve. It's the unmyelinated, and it actually innervates everything below the diaphragm. So everything below the diaphragm is what's innervated by the unmyelinated vagus. It is what gives us the freeze response. This is the very first thing that's laid down after conception in regards to the nervous system. We begin this unmyelinated vagus system. Then around the 16th week in utero, the sympathetic nervous system begins to develop, because the sympathetic nervous system is really the movement system. It's the system that allows us to move. You know, we say sympathetic nervous system is control in the adrenals, has everything to do with releasing cortisol, epinephrine. Well, what does epinephrine do when it's released immediately? It makes you move. Whether in your brain or your body, you're going to move. What does cortisol do? Gets sugar and oxygen into the brain so you can move, calms the immune system so you can move. So sympathetic nervous system is all about movement. Now, they developed this in what's called the Polyvagal Theory. The Polyvagal Theory is an explanation of how the Stephen Porges is the guy who developed it. Stephen Porges, Polyvagal Theory, he wrote a book on it. I highly suggest you read it. It's a great book. It's got a lot of science in it, but it's very easy to read. It's written very well. Okay, so one of the ways they first discovered this polyvagal theory was people who are babies that are born 30 weeks or earlier, premature, have a high tendency of sudden infant death, especially when they're scared. So if they're in an ICU or PICU and there's a lot of beeping, or sticking needles in them and doing things like that, if they're less than 30 weeks old and they get scared, this unmyelinated vagus can kick in and they go into a freeze response, and the heart rate goes so slow and the blood pressure goes so low that it's not compatible with life. Well, about the 30th week, the sympathetic nervous system gets mature enough that it can actually put the brakes on the unmyelinated vagus. I'm going to get back to this case in a second. I want to show you this, though. The sympathetic nervous system puts the brakes on that unmyelinated vagus. In other words, it keeps the person from going into a freeze response. What is a freeze response? It's called passing out. When somebody's passing out, that's a freeze response. Okay, somebody gets scared, it's a freeze response. So you want to keep that in mind. Now, around halfway through the third trimester, we have the smart vagus, or the ventral vagal system, that is developed, and it actually modulates the sympathetic nervous system. Sympathetic nervous system modulates the unmyelinated vagus. So to be healthy and adapt well to the environment, we have to have a good ventral vagal system. This is called our social engagement system. Our social engagement system is really highest on the hierarchy of complexities in the human system. So the ventral vagal system is important to be strong. Now, here's what happens in young females, teenage, early 20s. There's kind of a triad that happens. They have low blood sugar, they have low iron, anemic, and on top of that, they get an infection, a lot of times out of the bladder. UTI. You put this combination together and it can weaken these systems that are modulating so much, they just go into a freeze response. So, having said that, now I just know that from experience. I've seen that in a number of cases. Now, so going back to this history, it's a 19-year-old female presents with passing out without cause. What am I already suspicious of? Well, if your brain has two basic elements for fuel, it uses glucose and it uses oxygen. These are the two things that it uses for fuel. This is what it has to have for fuel. If you're low in either one of those, the brain can shut down. You can cause yourself to go through this. If you have not enough sugar or oxygen, both, you can cause these systems to crash down and all you got left is this very rudimentary freeze response, which is the vasovagal response, which is passing out, right? So I already know to look at, I want to look at blood sugar in this case. I want to look for anemia, and I also want to make sure there's no infections going on. Now, this part that she was checked out by a neurologist in Barnes-Jewish just means I'm putting my A game on because I really want to solve this case. I want to solve it anyway. But anyway, so these are things that she wrote on her thing. I keep fainting without a cause that we know. So what aggravates it? We can't tell. I went to a neurologist for a checkup. What do you think's wrong with you? I don't know. So that's what the case looks like. So let's look at some of our blood here. All right, so first off, right off the bat, what do we notice? That glucose is a bit low. We want to see glucose perfect at 85, but we give it a range of 80 to 90. When it is lower than 80, it means the liver is having problems with maintaining good proper storage of sugar in the liver, so it's beginning to go down. So 77 means that she's losing her ability to hold the liver. Now keep in mind, when we look at the liver, here's the liver, when we eat food, remember we only have about 4 to 5 grams of glucose in our blood, about a teaspoon, that's it. If we have as much as 8 grams in our blood, we can go into a coma, less than 2 grams coma. So average meal is about 75 grams of glucose. So you can't just go straight from there to there. So what happens is when you eat food, it goes straight to the liver. The liver's going to store 90, 95, 98% of it, depending on how much you've eaten. And only about 2 to 3% goes out into the blood, where it goes into cells and it gets used for energy. Okay. So, but think of it this way, the liver is the great modulator of blood sugar. When blood sugar begins to go up, your liver says, okay, I'm going to store some. And then when your blood sugar goes down, because now you're burning it up, the liver says, okay, I'm going to let go of some, right? So, but what happens when we start losing our ability to store sugar in the liver, then all of a sudden the serum glucose begins to wane and we get hypoglycemia. That's not just reactive hypoglycemia, but that's a further down the road, if you will. There's also something I want to pay attention to, which may or may not have anything to do with this case, but we want to look at it. Look at her triglycerides. Triglycerides should be 75 to 110. When they're at 70 right there, that means she does not absorb fat well. She's not absorbing fat well. Now I'm going to get on. You know what? Let's shelve that for just a minute because I want to talk about that. But to keep this in consistency, where it's hopefully easier for you to learn from, let me keep with the story we're on. We talked about low sugar. Okay, so if you've been around any of our teachings, you know that a lactate dehydrogenase less than 140 means reactive hypoglycemia. And the reason why is this: when sugar goes into the cell to be converted into energy, there's a pathway in there where you use lactate dehydrogenase. It helps you convert pyruvate to lactate. I'm sorry, I don't mean to get into all the biochemistry. But anyway, when you're crashing your blood sugar in between meals, this is what is largely going on. First off, you have a perfect blood sugar is 85, and sorry about this, I'm gonna get my thing here, is 85 right here. So when you eat food, sugar goes up, then you burn that sugar up, and then your sugar starts to go down, then your liver lets go of the sugar, and then you come back to normalcy. Well, what happens when people have congested livers? They don't let go of the sugar, so the sugar goes up, then it goes down, your liver's congested, it's not letting go of it, keeps on going down, 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 till it hits right here. When it hits right here, that's when your brain sends an alarm to the adrenals to kick out cortisol and epinephrine, and then you get a sugar spike, just leads to the next crash. Well, this time of being in this low area means that LD is not working as hard, so you're not making as much of it, so you get it lower than 140. It's a real good sign, unless they're on a ketogenic diet or a very low-carb diet, it's a good sign that they have reactive hypoglycemia. Here's another one that I've talked about before, but TSH, if it's lower than 1, a lot of times it can be what's called a tertiary hypothyroid, which means something's bothering the hypothalamus. Most common thing is an infection. So we look at white blood cells really look okay, don't look like infection, but neutrophils are at 67. They should be at 60 if you're not fighting anything. Lymphocytes should be at 30. Monocytes should be lower than 7. When monocytes are above 7, we think infection. When neutrophils are above 60, we think bacterial infection. And lo and behold, look, she had a bacterial infection. And then on top of that, for brevity of time, she had low ferritin. Now, it's not unusual. Look, the iron is high. You know why the iron is high? Because bacteria will compete for iron because bacteria uses iron to be able to reproduce. So it's not unusual to see total iron that's floating in the blood high, whereas your ferritin is low. Anytime ferritin is lower than 25, it can be the first early sign of iron deficiency anemia. So this 19-year-old female has iron deficiency anemia. So what does she have going on? She has reactive hypoglycemia, she has anemia, which is low oxygen, and on top of that, she has a bladder infection. That's the reason why she's passing out. So what did we do? Oh, by the way, the vitamin D was at 18, means she doesn't absorb fat well. I'm going to talk about that in just a moment, but let me get to what we did here. Okay, she had a urinary tract infection, hypoglycemia, liver congestion, iron deficiency anemia, and low vitamin D. Used a little bit of vitamin D. We had her follow food sensitivities and do blood sugar boot camp. If you're unfamiliar with that, if you've never seen any of my teaching, you can email me and I will make sure that you know about the blood sugar boot camp. We use Ferroshell from Designs for Health, 2 Ferroshell twice a day. Keep in mind, when you give somebody iron, make it 2 hours away from eggs or milk, because eggs and milk will cause you to not be able to absorb iron as well. It's always good to take just a little bit of vitamin C powder when you're doing iron, because iron is absorbed better in an acidic environment. And put a little vitamin C, you get some acid in there, and plus you get the benefit from the C. We use ACS silver, 18 sprays a day, 18 sprays 5 times a day. We use Uva Ursa. This was for the UTI. She responded from the very first day I saw her. She never had another fainting spell. I checked up with her, and I don't remember how many years ago that was. I did see her the first of this year, which was, so it's 2 years after this, and she still had not had one fainting spell. And I believe she had been having fainting spells off and on for about 8 years. But they would come and go. She'd have a lot of fainting spells and they'd go away. A lot of fainting spells going away. Why was that? Well, it's because, number one, she had in the beginning always low blood sugar, and that weakened her ventral vagal system, sympathetic nervous system. Then on top of that, as she, she's female, she began having periods, and then she developed some anemia as a result. Now keep in mind, when you have low blood sugar problems, it can cause you to have heavier periods because it screws up your progesterone, a whole, different story for a different day. But low blood sugar is very commonly at the root of dysmenorrhea. You always want to look when a lady has dysmenorrhea, look at the blood sugar. So anyway, so she had dysmenorrhea, now she has anemia. So everything's okay. She's passing out here and there, but then you put on top of that a UTI, and now she's passing out all over the place. It was it was one dark too many. It was that final thing that was causing the problem. We had a lot of success with her, but if you look at it, you think, oh my goodness, she just went to this major hospital in Missouri. It's a complicated case. How can I do it? Well, I didn't look at it that way. I looked at it as, I wonder what that blood sugar's doing. Let's make sure our body balance is good. I adjusted her. We do up her cervical. I checked to make sure she wasn't anemic, or that she was. I was looking for inflammation, so I actually ran food sensitivities. I was looking for infection. I found it. I was looking for liver congestion. I found it. Anemia. I found it. Blood sugar. I found it. Every single one, and we also adjusted her. Every single one of the 6 fundamental things were going on wrong with her. And no wonder she didn't need a new kind of herb or a St. John's wort or something like that. She just needed very basic fundamental work. Now, before I close, and I'm just getting ready to close, I'm going to ask for any questions in just a second, but I want to go over one more thing, okay? Because this is important. Okay, so here's the liver, gallbladder, and here's the small intestine, and here's the stomach. In the stomach, we have hydrochloric acid. Hydrochloric acid mixes with the food, and then when the food mixed with the hydrochloric acid hits the small intestine, there's a dramatic drop in pH. It's this dramatic drop in pH that activates your pancreas to release the enzymes. It's the dramatic drop in pH that activates your contraction of the gallbladder to release the bile. That's the reason why when people are on antacids, it's not just an innocent thing, I feel a little better when I do it. I work hard on every single patient that's on antacid to try to get them off of that. We have to find food sensitivities, address the reasons why they had the indigestion to start with. Maybe it's liver, GI, maybe it's gallbladder, whatever. You got to figure that out, because you can't have somebody for 20 years on antacid and expect them to be healthy, because if you have antacid, nothing goes good beyond this point. You have proteins hanging around here too long, and they have all kinds of issues. The next thing is this. When somebody has low triglycerides, and particularly low vitamin D, it is a sign that they have poor bile flow, that they're not absorbing the fat. So you want to look into that as an indicator. So in this person, they did have low blood sugar. They did have the anemia. They did have UTI, but she also had a problem with fat metabolism. And maybe when we go through and just get rid of the liver congestion, maybe she would do just fine with that. But you want to make sure that they're absorbing fat. Now, as a wrap, and the last thing, what I did with this person was this. I put her on a 12-week program. The first 2 weeks, I had her do blood sugar boot camp. I had her use uva ursa and the silver, because that was, something that she needed. I also had her use the fair shell, or the iron. Sorry about that. I also had her do the iron. Okay. So check her back in 2 weeks. We did her upper cervical care. Check her back in 2 weeks, see how she's doing. She was doing okay on the blood sugar boot camp, so she was finished with the first one. So I went ahead and had her do another one, but this time I did her 1 shake per day instead of 2. That way it lasted a month. We kept her, we did a urinalysis, and it was clear, so we didn't have to do that. In 4 weeks, we ran a CBC to see how she was doing. We also ran the ferritin to see how she was doing, and we checked the urinalysis, and everything was improving. And so that's how I would walk through that case. Okay, so right now what I'm going to do, Annette, are you there? And can you feed me questions if you are? I'm going to look and see if I can. Okay, the question is a very good one. The case of the 19-year-old, did you look at the lab from the hospital and then ordered your own? No, they didn't do labs in the hospital because they didn't know it had anything to do with it. So she didn't have any labs. So I just ran my own. I just ran my own labs on that. It's really not. And my dad used to say it this way. It's not really hard. And he was not a braggadocious guy. So I want to make sure that that's clear. But my dad used to say it's not hard to be number one. And he didn't say that because he was, full of himself. He said that because of his true love and desire for doing the chiropractic internist work. He knew that if we just do basic fundamental things and then use that foundation to grow on, we can do better work than the average doc in the box that's out there just prescribing blood pressure pills and cholesterol pills. We can do better work than that. We certainly can. In this case, it was even a neurologist out of Barnes Jewish Hospital. Okay, I want to say one more thing. I want to encourage you to sign up for the DAPSI. If you've not taken that course, we're going to go through the history and physical exam. We're doing that. It is December 5th and 6th. You can call our office at 573-341-8292, or you can email Virginia at drkessinger.com. and I'm going to be teaching that class. I'm already ready to go. We have tons of case studies we're going to go through. Don't think it's going to be a snoozer because it's history and physical. You're going to learn a ton of information. I see another question just came up. I will look to see if I can answer it. Okay, thanks, Doc. Thanks. And by the way, thank you guys. I see some of you guys that are in here. Every time we do this class, you guys are here. And I'm so thankful for all of you. I appreciate you so much. You guys have a fantastic Thanksgiving. Enjoy your families. Enjoy your time. You know, we are living in some of the greatest times ever. And Godspeed you guys and all the great work you're doing. So good night and God bless.